Welcome to Capnography for EMS.com, your source for EMS education with capnography and anything related. Capnography for EMS by EMS. I'm your host, John Syverth, and today we're going to be discussing the use of capnography for intubated or invasive measurements. So what we're doing with this third episode is we're building upon the first two, which covers capnography, what its use is for, and what the abilities of this device can do for us in our assessments and our patients. And the most critical of those, whether you're using capnography for intubated or non-intubated or both, we need to completely comprehend and understand how to utilize capnography for those critical situations. So today that's what we're going to be covering. Once again, let's review capnography, the vital sign of ventilation. We track carbon dioxide in the patient's exhaled breath. We're objectively evaluating the patient's ventilatory status, and we are indirectly evaluating the circulatory or metabolic status as well. All three must be present for carbon dioxide production in the body and for us to get that end-tidal CO2 reading. So we're assisting the care provider with clinical judgment to assess and treat their patients. Okay, that's what these messages are all about with these lessons. So one of the most critical and important aspects of capnography is confirming, maintaining, and assisting intubation. If we don't get this right, some people are in some serious trouble. And I'll give credit where credit's due. Occasionally I have some strips that I've pulled up over the internet over the years, and there's some wonderful websites, and we're going to cover some of those today, just as we covered Troy Valenti's book, King of the ABCs. And some of these strips come from emscapnography.blogspot.com. That's a good source of information for capnography, and they oftentimes have several links to different information as well. So this strip is from that website, and obviously what we're seeing here is a nice flat line, which isn't very nice for the patient, right? And in this aspect we're trying to confirm intubation, and we have this flat line. Well, this flat line, providing we're doing CPR if need be and ventilating the patient appropriately, and we have everything hooked up correctly, this line should not be, right? We should get some sort of waveform that's confirming that our tube is in place. Okay, so bottom line is, if we just have a flat line, we've got big problems. Okay, then we need to reevaluate our situation. And a lot of people will say, well, I only need to listen to lung sounds, yada, yada, yada. Listen, we should have all the tools at our disposal as possible, and we don't need to make excuses why not to use them. I can't believe how many people that are very experienced and intelligent say that they don't need something else to help them do their job better. Okay, it's like saying that I don't need to learn anything else. That's just nonsense. So most of us think that have any experience of capnography think that the flat line is the only thing that we can show as being a missed intubation, to where the tube is in the esophagus and not the trachea. That's not necessarily the case, and capnography.com is another great site that references where this material is coming from. And you can see with these different illustrations here that you can actually have different manipulations of waveforms, not necessarily adequate waveforms, that may be caused by certain things. You can see this one I just circled. It could be an esophageal intubation, and there might be carbon dioxide in the stomach. It could be carbon dioxide from carbonated beverages or what have you. And capnography.com is more geared towards anesthesiologists, so sometimes it can get difficult to navigate through, but nevertheless is a good site for trying to learn. And we can all, when we're trying to learn something new, we can all have additional resources, and that's partly why I've been putting together these videos, is to augment sites such as this. So looking down here, we can see esophageal intubation here. We actually have a really nice waveform, but that waveform fades off after a while. Okay, I have personally never seen this, but where I think you maybe would be more possible to see this is in the instance where maybe you place a tube and somehow you manipulate the head or neck, and the tube slides out in the posterior pharynx slightly. Okay, so you might actually have a decent waveform to begin with, and then it starts fading off. The same thing could happen possibly with a cuff leak of the tube, or I can see where a king airway sitting there in the posterior pharynx has a little bit of a cuff leak, and it causes a distorted waveform to where maybe it starts fading off over time, such as this. Okay, and then on the bottom we have what's also shown to be possible carbonated beverage, and from a glance this can almost look like the curar cleft. Okay, so we have to be a little bit careful. If we're getting continuous distorted waveforms, we need to question why that's happening and reevaluate what's going on. It's very possible that you could have this type of waveform and where it's in the esophagus and you have a lot of carbon dioxide buildup in the stomach. It's always possible to somehow forcefully move carbon dioxide in the stomach when we're overzealous with our bag valve mask ventilation. Maybe there's some recirculated carbon dioxide somehow in the dead space that gets moved to the esophagus. Though I don't think we would have huge readings like this. We'd probably have readings more like this again. Okay? So those of you that haven't seen Capnography for EMS.com, we can pull that up real quick. It's a pretty nice site if none of you have been to it before. Don't fail me now. There we go. And there's different places you can go. You can see that those capnograms were just in here that we had just seen. Okay. And the doctor that runs this website is an anesthesiologist. A lot of information, but can be overwhelming to some of us that are brand new. I spent a lot of time over the years going to the site to try to learn more and more. But he has physiology and trends and all the different things that are really pertinent to what we do. However, if we start reading right here, most paramedics have ADD, so we can't handle all this stuff. So purpose of mine, my videos are to augment what these sites are providing also, and maybe once you get more practical experience, it might be easier to go back to these websites. So let's get moving along here. Here's a tube confirmation, and you can see right here is where we got the end-tidal CO2 hooked up with a bag valve mask and a tube in place. Okay, and so here's our first tube confirmation right here. Now, tube confirmation, really you want to think about when you're truly know for sure that a tube's in place. You want a good 6 breaths before you know for sure. Okay, that way you know that you're not going to have any issues like we just saw on the last screen, where you start out with a good waveform and then all of a sudden it's gone. Okay, we have to be vigilant with monitoring all of our devices, especially our capnography waveform on our monitor when we're either confirming, maintaining, or assisting with intubation. Okay. Now the nice thing about this this waveform here, you can see again, nice and square. Nice and square. Okay. And the level isn't too bad. You can see here it says 28 millimeters of mercury, so that's not too bad. And if I recall correctly, this was where we were performing CPR, so you can see that 28 millimeters of mercury with performing CPR is actually pretty darn good. Okay. Now that we see there's a normal waveform and the level is actually really good, we also want to look at the rate and regularity. Now mind you, we're bagging the patient here and we first got our intubation. So sometimes when we get our first intubation, we want to move quickly to listen to lung sounds to confirm that tube and get those breaths in, those 6 breaths especially. Okay, so our ventilatory rate is actually a little quicker here than it needs to be. Remember, these are about 10-second strips, and 3 times 6 is 18, so it's a little bit quicker than what we normally do, but for the purpose of tube confirmation, I don't get too worked up about that. If this continues on, then we're going to have problems. So waveform's nice and pretty, the waveform height is real nice, and our rhythm and regularity is, our rate and regularity is pretty decent from this point. Now if we go to the next slide, we can see that this is a patient that was intubated, and this was a ROSC patient where we had a very good outcome long-term also with this patient. However, you can see that with ventilating this patient, someone was getting a little too excited, and we were using a bag valve mask. You can see that the waveform is actually pretty decent looking, maybe a little bit of an upward slope. Maybe he was a smoker, which I think this patient wasn't the beacon of health, but the rate is rather quick, and then we have some irregularity going on with our bag valve mask ventilation as well. Now you're going to say, well, these smaller waveforms could also be the patient maybe fighting us and he's not well sedated. That might be the case, but if I were to pull up this trend report on this, which I've done before, you can see that this ventilation rate continues like this, and there's no indications from the patient care report either that the patient needed additional sedation or anything of that nature. So what we ended up having is a respiratory rate, the average was probably 25 to 32 a minute. Okay, way too much. What ended up happening with this waveform is the waveform kept on getting smaller and smaller. So the CO2 was actually moved down to around 20 millimeters of mercury. Okay. The important thing to remember with ventilation is we most of us by now understand that we don't hyperventilate patients. Now, we have to be careful when we say hyperventilate, because what we're really trying to avoid is we don't want to create hypocarbia. Okay. Hypocarbia means that we have low CO2. Okay, so we inadvertently made this patient hypocarbic, which when you hyperventilate a patient and make them hypocarbic, you are also reducing blood flow to the brain, causing constriction of the vessels which lead up to the brain. So you are actually causing reduced blood flow to the brain, which is the most injured part of the body when it comes to cardiac arrest. Now, as we cover later, hypercarbia is actually just as bad. So if we are hypoventilating a patient either by not providing an adequate rate or an adequate tidal volume, we can actually cause just as much damage to the patient, though the blood flow to the brain then is actually increased. However, carbon dioxide, there's so much acid in that blood that we're not able to circulate it off through the lungs, and then oxygen isn't moving through the alveoli as well with all the carbon dioxide. Here's also another good illustration from EMS Capnography blogspot.com, and this one is reflective of our trend report, which I just mentioned. Each one of these little hashes here is every so many moments, and I don't know exactly which one this is referring to, because you can do trends for 1, 3, and 5 minutes or what have you based on the monitor. But you can see over time that this is a cardiac arrest where they're working, and then they get this spike in end tidal CO2, and then they lose the patient, and then they get a spike again, so on and so forth. So this is a good illustration of what we'll be covering here in a few moments, of where you're doing CPR. You may not have optimal cardiac output, which is what's reflective here. And then once the patient regains pulses, there's a little bit of a CO2 washout that flushes out of the system because perfusion has increased that much better because the heart has started beating again. Okay, so then you have that CO2 washout, and sometimes it does level out. Okay, you may have a 15-20 point increase in carbon dioxide, but usually it'll level out because the body returns back to the normal carbon dioxide production and output. When someone's heart stops beating, blood's no longer obviously being circulated, so therefore carbon dioxide isn't being produced and circulated in the same way. So we do get some buildup of carbon dioxide, but it's not nearly as much as if someone had stopped breathing first and then their heart stopped. If someone's heart stops breathing first, we have a huge backload of carbon dioxide buildup in the circulatory system, just waiting to be offloaded by the lungs. So a little bit of a different scenario where a patient is like truly hypercarbic, where they're off the charts with their carbon dioxide levels. But nevertheless, ROSC usually anywhere from a 10 to 20 point increase in carbon dioxide on the short term, and typically, like I said, that just levels out relatively quickly that way. Okay, so let's look at one of our cases here. Here we have an intubation confirmation, and here's our initial waveform. Not the prettiest, but it's there. And then as we continue on, we got our additional waveforms, and we can see here that the waveform is nice and square, so we don't have to worry about any bronchoconstriction or anything that may make us think that we need to treat the patient any differently. Okay, this may have been a sudden cardiac arrest versus somebody who stopped breathing first due to an asthmatic or COPD event. Okay, so nice waveforms. However, we have a short squatty waveform, and maybe an end tidal of 17 or so. You can see here that this line is our 35 mark, which would be right around normal normally. Okay, and then you can see down here we have CPR continuing. And so initial CPR was here with tube confirmation, and then tube confirmation and rescue pod. Remember how I showed you the one previous episode? I showed you the cardiac oscillations from CPR without a rescue pod. There's a good example of having a nice clean waveform with a rescue pod that helps us determine whether things are going well. And you can see there is a little bit of irregularity with whoever is bagging this patient, which is also why I really like to use a vent for that purpose, is that we can control our ventilations a little bit better, and then we know that when we're controlling our ventilations, whether it's on a patient who is in cardiac arrest or just rapid sequence intubated, we can control the ventilations. And remember, capnography comes back to ventilation, perfusion, metabolism. Well, if we're adequately controlling ventilations to where we know we can control rate and tidal volume very precisely, and then we're also, say in this case, doing really great CPR, but we have a really low end tidal level, then that might tell us that there's some kind of additional perfusion or metabolic issue going on as well. Okay, and then you can see down on the bottom here we have ROSC. Okay, and you can see with ROSC we have a beautiful waveform still, and you can see that our end tidal level shot up, and it roughly doubled what the original end tidal level was. So we went up about probably 17 points here in this instance. Another interesting use of utilizing capnography actually happens with pacing. And we had a very difficult cardiac arrest where the patient was asystolic with our initial treatment and was not responding despite our best efforts. And so this is CPR here, and we're doing compressions, and that's our pads lead. And you can see here that we actually have a decent amount of cardiac output with our CPR. We're probably sitting around 30 or 28, somewhere in that area, and not too bad. But we were getting tired, and we felt this patient, being that she had such a good level of carbon dioxide, that there is a chance that she's still savable, and maybe we just need to get her to the hospital. Well, CPR just wasn't quite doing enough of the trick, and we had been there for a while on the scene trying to work with her, and so we decided to go ahead and pace this patient. And when we did start pacing this patient, we got great capture, which we can see here, and you can also see that we had a really great waveform then. Okay, So why do we have a really great waveform? Because the pacing was actually more productive for the patient than performing what we felt was very adequate CPR. Okay, so this pacing was actually causing the heart to contract better than our CPR would, which shows, one, CPR, no matter how efficient we are, is not always the most efficient, and two, may give a better cause for providing pacing in certain situations, say in an asystolic patient where CPR may not be the best answer. It's always possible that someone went into cardiac arrest because some kind of pacing mechanism of the body just wasn't working right. Maybe there is a vessel blocked in the coronary arteries that is causing conduction delay, okay, or inhibiting conduction all along. So it's always possible that we have a savable patient. We could just pace them going into the hospital, and this is a great indication that our pacing is actually working and that we're getting great capture for sure, okay, not just feeling pulses. But what is our body doing on the downwind effort or effect? And what I mean by that is, what kind of carbon dioxide production is that body producing? That gives us a better indication that oxygen is getting to the tissues and is being processed appropriately. Because if the oxygen is not getting to the tissues, then it's not necessarily going to be producing, the body won't necessarily produce carbon dioxide. It'll produce something like lactic acid instead. Okay, so this is a good indication, one, that she maybe wasn't down very long, and two, that she's still savable at this point in our minds. So the next one, verification of circulation. Here we had a patient that was an unwitnessed cardiac arrest at a nursing home, and she had been rather ill to begin with, and we'd work on her quite a bit of time, and then what ended up happening was she had an internal pacemaker, and her internal pacemaker started getting some capture. So we got some capture, and we weren't exactly sure if we had a pulse, and feeling for pulses sometimes is very difficult as well. So we took advantage of our capnography, which we had already had attached, and we had confirmed with our CPR that it was tube was in place and everything was going well. And then with the pacer, here we are getting at least some fashion of a waveform, okay? And we can see that this waveform is very, very low, okay? So we're ventilating at a good rate because this is all one ventilation pretty much over this entire strip, which is roughly 6 seconds, okay? But we can also see that that is a relatively low number, and we're probably around 12 or 15, somewhere in that area. So not very effective as far as circulation is going with this patient. The irony of this whole situation is that I had gone out to the medic unit to call the hospital to terminate resuscitation just prior to this because we'd been on scene so long and we're not getting any responses. And as I'm getting approval, they're radioing to me that now they have ROSC. So we met up with one of the senior medics and we discussed the situation, and we didn't think that she was going to be able to remain with pulses on her own, and we didn't think she was necessarily a savable victim that may require transport. So as we're getting this patient packaged, I also called back on med radio and described that same exact situation and said we wanted to monitor her for a few more moments before we transported and see how well she held up. Hospital was okay with that, and we moved on with still getting ready to package the patient, but also monitoring our situation, being that we weren't confident that she was going to maintain this at all. And partly that was because of this reading here. That's such a low reading, and sometimes people just die, and that was going to be the case with this lady, as we can show you in the next slides. So here we have actually a buildup right after ROSC of carbon dioxide. Okay, so we're actually a little bit better, and this is probably in the process where I'm talking to the on the med radio for the second time. But then as time goes on, we can see that we have a decreasing perfusion again. We still have a good ventilation rate, but we're dropping again. And also notice that our capture is not as precise and as good as it was before. Moving on, we have an ever decreasing amount of capture with our pacer spikes, and our waveform is getting progressively worse. Now the nice thing about this situation is that we were controlling ventilations with a ventilator, so we know that we have the adequate tidal volume and ventilations. As I mentioned before, ventilation, perfusion, metabolism. Okay, well, ventilation's covered. We got a good respiratory rate and we got a good volume. Perfusion, well, here's our perfusion status right here. Okay, and it's also showing right here. Metabolism, blood glucose checks, things of that nature are going to help weigh the situation and find out if we do have some kind of other issues such as ketoacidosis that may be causing this number to further drop. Because if we have some type of metabolic acidosis, this end tidal waveform is going to be very low as well, and our numbers are going to be very low. So it could be contributing to this problem, but most likely we have a perfusion issue, if not some other type of underlying issue of perfusion such as sepsis or something like that. So moving along, now we have very little, if at all, capture with our pacer spikes. And you can see there's actually, even though that capture is there, we actually still have a little bit of a waveform. Now it's important to remember that once we start getting down to these lower levels, I think in our Philips monitors our level is 8, to where it will not actually show up on the screen. So in order to verify this, you actually need to print out sometimes whether or not there is a waveform present. Okay, and then here we have our termination of efforts, where this patient essentially had no capture from their own pacer spikes, and resuscitation seemed futile at that point. And you can see there might be a very low blip right here of the last final ventilation, where there was probably over the course of time residual carbon dioxide in that dead space that had to been blown off and cycled out with ventilation, even though we had these pacer spikes and no capture at all. Another good example of where we might actually be able to have a waveform for a short amount of time, a very short amount of time, if there's any residual carbon dioxide that is able to be blown off from the lungs despite lack of pulses. Okay, so here's a challenging situation. We have an endotracheal tube in place up here. However, we don't have a waveform. Now, our cardiac arrests are not always the cleanest, most controlled situations, and this one was not. I think this one ended up as being a brainstem herniation. There was vomit and there was poop everywhere, and the paramedics had a difficult time because in the process of attempting to place a tube, and then subsequently I think there was a King Airway attempt. They had a lot of vomit in there in the way, and just a nasty all-around situation. We were new to utilizing the capnography in a much more aggressive fashion than we had in the past. If you remember, we originally started out with just intubated capnography versus non-intubated, and this is a great example of why we need to apply capnography more often. We were in this transition phase, and we had a lot of people that were resistive to the efforts being concerted with non-invasive use. And ultimately, the most important thing is that we're getting exposure to our paramedics and our EMTs with understanding what they're looking at. So we had an issue where capnography was placed, but the tube wasn't in place, and it wasn't the waveform, the lack of waveform, was not trusted by the paramedic, because they swore up and down that they heard good lung sounds. And then they also, I think, use a colorimetric device, which we still had at the time, as a backup plan. Well, the problem with the colorimetric device is this patient has been puking, and it's very possible that acid was in that airway and could have given a false positive as far as a tube placement goes. Okay, so I believe the colorimetric device did change color. However, we have a good flat line here. Okay, so what else could be causing the problem? Well, it's very possible that there could be up tube in place, but we have maybe something clogging the interior port where that little line, the filter line, comes off of the connection for the capnography on the tube. Okay, every once in a while you might get a little a chunk of vomit or something that gets up there and plugs. Well, the problem is that what you're going to see then is those dotted lines right here. Okay, so if your filter device is not getting a clear pathway from the monitor to the tube, it's going to throw up these dotted lines and it's not going to show a flat line. Okay, the flat line is showing that this patient's being ventilated, or it shows that the capnography is hooked up. So if we just hooked up a capnography device right now, as soon as it's hooked up, the computer senses that there's a pathway down that tube to where it can measure carbon dioxide, but it's not measuring any carbon dioxide. It can't sense anything. So it's going to give a flat line versus a dotted line. Okay, so it's important for us to understand that. I'm not entirely sure that the people that were using it this day completely understood it, though we had some people there that did know what they were doing. Okay, they had been learning like they should have, and unfortunately had some barriers to the situation. And it's sad and unfortunate that this patient, this situation continued on for a little while with no waveform, as you can see here, quite a few minutes into the situation. So finally, a couple of the guys finally smarted up and said, hey, something's not right here, this doesn't make sense. We have a positive confirmation from a colorimetric device, but we don't have this on, we don't have a waveform at all. And you know, I've never seen that, so we better pull this tube. So they did right by pulling the tube, and what they did that was awesome, which I'm very thankful for, is they pulled the tube, but they also kept the capnography on the BVM. What that helped show was that now with the bag valve mask, they were getting a great waveform. In fact, they were getting a relatively normal waveform. This might actually be the patient breathing, because I'm guessing that this patient may have actually still been breathing a little bit on their own despite the tube being placed in the esophagus. So luckily for this patient, and at least as far as that goes, even though they had a significant brainstem herniation, they did not go hypoxic or hypercarbic, because we would be showing that here when we're bagging the patient. Okay, now let's move on to the next row here, and we can see that some of these waveforms are not very pretty. Like I said, it might be partially them breathing, or it might just be poor handling of the bag valve mask. In other words, you might have some leaking around the face, okay, because you don't have a good tight seal, or the fact that sometimes we lose our grip on a bag valve mask. Remember, there's a bunch of vomit and poop around. It's very possible the bag valve mask was slipping out of the person's, the caregiver's hands. But even more to point out is this waveform right here. See how it's kind of sloping? It's sloping a little bit because we have a delayed exhalation all of a sudden. Well, why do we have a delayed exhalation? Well, we're bagging with a bag valve mask, okay? So we can't really diagnose bronchospasm with just the bag valve mask without that controlled airway. We could have a tongue falling in the back of the throat. The airway might not be open completely, like a head, tail, chin lift kind of thing, jaw thrust, okay? But where the bag valve mask in combination with capnography is so great is that you can actually ventilate the patient before intubating and know that your ventilations are getting in place. Or in the case of a drug addict, where you just need to support ventilations for a very short amount of time, you can help identify whether or not the ventilations are getting in the right spot. Okay, we still have to take our numbers, our measurements, with a little bit of a grain of salt, because we were talking about dead space before. When we have a bag valve mask, we have a little bit of additional dead space around the face that could cause actually a falsely low reading that maybe is slightly off, but not that much for me to be too concerned with knowing that ventilations are getting in and out. Continuing on, you can see these guys are doing a great job in their bag valve mask with the tube pulled still. They have a great waveform, they have a great rate, and then they continue on in order to the hospital. They just continued on like that. They decided to cut their losses and bag the patient on the way to the hospital. Nothing wrong with that with the given situation. The most important thing is that it was identified early on, not as early as we'd like, but at least we identified the situation as quickly as possible, and surely we have learned from this, and that we're going to be more vigilant at understanding what we were dealing with in this type of situation in future ones, to prevent any miscommunication or mishandling of an incident. So for intubated applications, we've discussed most of this today, and we'll cover the rest right now. So we use capnography with our bag valve mask. I cannot stress that enough. If we're hooking up a bag valve mask, we should be hooking up our capnography to that bag valve mask, or in some situations, we may be able to use a non-invasive filter line on the patient first, and we may determine, so we have a cannula on the patient, and we may determine that they need to be bagged. We can just leave that cannula on in place instead of switching out to the intubated version, and that will help us get it'll help us get a truer measurement of carbon dioxide release from the lungs, because that capnographer is that measuring device is right on the tip of the mouth and nose, versus on a bag valve mask you might have a little bit of extra dead space in the mask itself, because on a bag valve mask we have the connection here, okay, and then right on here is where we would place our end tidal going to the monitor, okay, and then over here we have our bag valve mask. I know it's a beautiful drawing, I'm an artist. Okay, so in here we can have extra dead space, which basically causes carbon dioxide coming from the lungs to not fully expel out through our device, okay, which then causes a little bit of mixing of air down in here. So carbon dioxide actually does not fully escape, and it can actually get recirculated back down into the lungs. Okay, so if our actual reading is 35 down here, we may actually only get 30 up here. Not the end of the world for me. So use with bag valve mask for sure, and then use with intubation. Tube confirmation, we can even use it for nasal intubation. Put that capnography device on the end of the tube, and then while you're listening and feeling for the tube to get into place, you can also monitor the waveform, or the presence of one or lack thereof, with that tube placement while you're looking at the monitor. Maintaining proper carbon dioxide levels. If we're managing that head injured patients, we know that hypocarbia is a very big enemy for head injured patients. In some cases you may need to control ventilations in one direction or the other for certain types of ICP. However, the majority of our patients who have head injuries and have associated trauma with the rest of the body, we really need to control ventilations that we're not making them hypocarbic, or hypercarbic for that matter. Okay, so hyperventilation is not necessarily the enemy. Okay, hypocarbia is. And on the flip side, hypercarbia is, which would be related to hypoventilation in many instances. Okay, limiting pauses and compressions. We know that the better we do compressions, the more often we do compressions, and continuous in nature, the better off we're going to be doing for the patient. So not only need proper depth, we need proper rate, okay, and we need a proper ratio. And what that ratio is the amount of compressions, the amount of time that you're actually doing compressions versus the amount of time that you're not doing compressions. So if we're stopping compressions to do an intubation, well, that's just wrong. We should be doing continuous compressions at all possible, and we should be limiting our pauses to less than 10 seconds, okay? Preferably less than 5. So when we're using, we're doing CPR and we're utilizing capnography, we may actually have cases where we're working a patient and we don't need to stop every 2 minutes. Some people freak out when you say that, but let's face it, we don't always need to stop every 2 minutes. And in some cases, the only reason we're stopping is because we're getting fatigued from CPR. Maybe we're doing really good compressions and we have an ability to measure that as well, partly in capnography. And we can continue on with our compressions a little bit longer in order to limit the amount of times we stop. Maybe we want to keep on going for another minute or so because we're getting ready to push another med in. If we're getting ready to push another med in, why should we stop right now to switch out compressions? Maybe we can continue on and then switch out with the presence of the medication being pushed at the same time. So gauging the quality of CPR. We just briefly touched upon that, but if we're doing really good CPR under normal circumstances, we can get an adequate CO2 level, a relatively adequate CO2 level, and theoretically if we are providing adequate CPR and providing adequate controlled ventilations with tidal volume and rate, then we can gauge the quality of our CPR by our end tidal reading. If we're getting a really, really low end tidal reading, well, remember, capnography in combination is ventilation, perfusion, and metabolism. We need to have all three present, and then based on what we're doing with this patient, we can maybe help navigate through the waters to decide whether or not this patient has a perfusion issue, a ventilation issue, or metabolism issue, or all of the above. Okay, so perfusion would be a byproduct of quality of CPR. So if we're doing good quality CPR, it'd be reasonable to expect that we should be getting a really good or decent CO2 level. Okay, in the case that we have really good CPR, and we can confirm that, and we can confirm we're not hyperventilating the patient, then we might think that there's some underlying perfusion issue involved that we need to help treat, or we might have some type of underlying metabolic issue that we may or may not be able to treat as well. So how about determining probable ROSC? Well, hopefully more and more of us are catching on now that we can, for sure, determine ROSC with capnography, or likely ROSC. The important thing for us to remember is if we see end tidal levels shoot up while we're performing CPR, we have a controlled airway, we have our capnography hooked up, and we were at 20-25 millimeters of mercury to start out with, and it increases to 35, chances are we're going to be getting back ROSC pretty soon. The important thing is that we continue our CPR for up to 2 minutes while we're waiting for the body to kind of gain its own traction, so it's not spinning its wheels. Okay, so if we continue our CPR for another minute or so, it'll allow that heart to keep primed and then allow the body to recover a little bit quicker once the heart takes over on itself. And then I just kind of delved into it a little bit, and we're going to get into a huge amount of differential diagnosis in the near future with additional presentations. But especially when we have intubated applications involved and we can control things such as ventilations and possibly perfusion with CPR, we can really aid our differential diagnosis abilities and help us come to better conclusions as to what's wrong with the patient. Okay, we can talk a heck of a lot about that, but we're not going to do that today. So once again, our closing points. When we're incorporating capnography, we have to do a complete assessment. We just don't look at capnography for itself, but we look at the whole patient and look at all of our different signs and symptoms and all of our assessment skills and put it all together to come up with a more reasonable approach to how we treat and assess our patients. The more you use it, the more you learn. The more you learn, the more you want to use it. Okay, ventilation, perfusion, metabolism. All three need to be present, and any one of the three or all of the above can affect your carbon dioxide readings. And let's remember that we need to evaluate not only the waveform, but we also need to evaluate the numbers, and we need to evaluate our trends over the course of time to see if the patient is the same, worse, or getting better. So for now, I'm John Seiberth, and we'll see you again. Take care.